Hello again. I hope you all are well. And in part one of asthma management of my this series of 4 lectures, in part one I covered about what is asthma, how does it happen, what are the phenotypes, what are the endotypes, and if you see a new patient of asthma, how should you approach? I hope you remember those things. In the part 2, I'll be covering how do you approach, which includes the clinical features and diagnosis, as well as the initial part of management, the most important part of management, that is the prevention of asthma. So when you have almost suspected that your patient has got asthma, the most important part is you should identify the positive history. That means whether it is extrinsic or intrinsic asthma, whether it is atopic or non-atopic asthma. I hope now you remember the atopy. You remember IgE level is high, then it is atopic asthma. So you should take thorough history, which are the triggers, which are the conditions, or which are the situations when your patient develops the bronchospasm. You should do physical examination of your patient to identify whether patient is in distress or not. That is very important. Patient is perfectly all right and they have just come for checkup. You can go ahead with spirometry with post-bronchodilator reversibility. I'll discuss that. What do you mean by post-bronchodilator reversibility? As well as if you do not have spirometry, don't worry. You can do even PEFR. So with this armamentarium, we can go ahead with how do you diagnose and treat asthma. So the clinical features of asthma: cough, wheezing, chest tightness. Yeah, we know the asthma triad. That is what it is. If your patient comes with this, you should suspect that they might be having asthma. The symptom time, you should ask when is the time, what is the time of the day when they develop maximum symptoms? Is it in early morning or is it late night? Which are the triggers? That can be dust, smoke, seasonal variation, exercise, chemicals, animals, bird products, pollens, drugs, URTI, or emotional disturbances. These all the things sum it up about asthma history. If you ask this much things, definitely you can conclude that patient has got asthma or not. Now, when I told about physical examination, it's very important because sometimes patients land up with you when they are actually in exacerbation. So please spend a time to do a clinical examination of your patient. Find out whether that accessory muscles of respirations are working, whether they are confused, whether they are hypersomnolent, that is indirect sign of hypercapnia, or paradoxical pulse. I'm sure you should know from your MBBS days what is paradoxical pulse or pulsus paradoxus, where the blood pressure goes down on inhalation more than 10 millimeter of mercury. So these are all the clinical signs of asthma which will help you to differentiate a stable asthma from the unstable asthma. Now coming to the stable asthma. When your patient is stable, you have done clinical examination, you have done initial blood investigation. The third most important part in the diagnosis of asthma is spirometry or pulmonary function test. So the pulmonary function test is the entire set of pulmonary function tests, while for asthma, the most important thing is spirometry. Spirometry is not only important in the diagnosis of asthma, but it helps in the monitoring of the treatment, as well as sometimes you are able to diagnose occupational asthma, as well as assessment and disability and impairment certificate is also on the basis of spirometry. This is a flow volume loop which you will get by doing a spirometry. I have divided it into three parts as per the severity. Remember that the patient has to blow in the machine and then the flow volume loop is created. This is a time volume curve. So the values will be given in the bracket, something like this: FVC, FEV1, FEV1 upon FVC. So when the FEV1 upon FVC is less than 70%, you should label it as an obstructive asthma or obstructive airway disease. And when the FEV1 absolute value is between 80 or greater than 80, it is mild. When it is between 80 to 60, it is called moderate. While when it is less than 60, it is labeled as a severe asthma. The PFT itself needs a separate presentation and we might take it later on. For now, just remember that spirometry is important, and when you are suspecting asthma, you should also do post-bronchodilator reversibility. What do you mean by that? So in subjects where you have found that airflow limitation is present, you should offer them bronchodilator after doing the initial flow volume loop, and you should repeat the spirometry after 20 minutes. If you find that the FEV1 has got improvement or increase in the values from the baseline values to the level of 12%, or there is an absolute improvement of around 200 ml after bronchodilator, that is 200 micrograms of inhaled salbutamol, then you can label it as a reversibility. So you should do spirometry first. You should find out whether patient has got asthma. If you find that patient has asthma, you ask them to take 2 puffs of salbutamol, that is saline inhaler, via spacer. Ask them to wait for 20 minutes. Repeat the same process again and see the values. If you find that the values are more than 200 ml of absolute as well as the percentage, it will be a machine generated values. Please don't worry too much. It's easy, and I can talk about it later in the detail. So that is what the spirometry is. It helps in the diagnosis as well as management as well as prognostication. Now what if you do not have spirometry? Then there is a handheld device called peak expiratory flow meter, which will you have to ask the patient to hold it, inhale full and blow, and there will be a pointer which is moving up and down, and by the airflow it will move down. So what will you measure? You will measure the highest expiratory flow obtained during a forced expiration starting immediately after a deep inspiration from total lung capacity. Don't worry, you just have to ask the patient to take deep inhalation, put the device in the mouth, ask them to blow and see the value. That's it. It can be used for the diagnosis if spirometry is not showing reversibility, or if you do not have spirometry. It correlates well with the FEV1. There are many studies to say that. So what do you do with peak expiratory flow meter? So you ask your patient to buy one peak expiratory flow meter of their own. Tell them to monitor daily when they get up, before sleep. Maybe in the afternoon also if they develop increased symptoms. Morning and evening values are recorded for 2 to 4 weeks. A diode or variability. So as we are aware that the early morning values will be low compared to the night values, and that variability or that change should not be more than 20%. If it is more than 20%, then it is labeled it as asthma. So I'm sure that you are now knowing little bit about PFP or spirometry and peak expiratory flow meter. The next most important thing for us is chest X-ray. Why? Because all that wheeze is not asthma. I'm sure I'm not the first one to say that to you. And that's why you should do chest X-ray and find out that it is asthma. Because in asthma, the X-ray is apparently normal. You should do ABG, not all the patients when it is indicated. Allergy testing, yes, to find out which are the commonest reasons or triggers for them, and sometimes patients are asking for that, you can do. Exercise testing, if the exercise induced asthma is the clinical history suggests that only at the time of exercise it happens, and you can do exercise testing. You can do different kind of bronchial provocation tests. Bronchial provocation tests are done only if spirometry is normal. If your spirometry is showing clear-cut asthma, you should not subject your patient for bronchial provocation. It can be dangerous. We do not do it in our clinic. As for diagnosis, additional tests you should do CBC, you should do total IgE. IgE does not help only for the atopic asthma, but there are sometimes a difficult to treat asthma like ABPA, in which also it will help. Then there are sputum eosinophils and sputum cast, which will help in the diagnosis of asthma. And there is an XL nitric oxide. Now, asthma differential diagnosis, when I told you that you should do chest X-ray of your patient, I was talking about that not all that wheeze is asthma. Sometimes the foreign body can cause a localized wheeze. Tumors can cause localized wheeze. Vocal cord dysfunction is very common. Believe me, more common than you can think of. And whatever we do, there is no improvement and there is a fixed bronchi on both the sides. And it happens particularly in the adolescent age group. and children will be coming to you again and again with asthma exacerbation, and you will be clueless what you can do more. So vocal cord dysfunction is also happening in our clinical practice. Then there are some similar diseases like COPD or bronchiectasis or just LRTI, as I told, mycoplasma and chlamydia, very well present with asthma symptoms. Then there are eosinophilic bronchitis or pneumonitis. And don't forget the cardiac asthma. So these are all the almost mimics of asthma. Then there are some coexisting conditions which can aggravate asthma or may present like asthma, like GERD or GERD, pulmonary embolism, pulmonary eosinophilia, or drug-induced bronchospasm. You should keep all this in mind, but if you will take your clinical history properly and do the investigations which I have asked, it should not be difficult for you to differentiate differentiate asthma from the other diseases which I discussed. Now, the most common diagnostic dilemma is to differentiate asthma from COPD. So, uh, that is also very easy because asthma happens early in life. Not always, but mostly. While COPD, the definition itself requires some age group, like more than 40 years or mid-late in life. In asthma, symptoms vary from day to day, while in COPD, it is a slowly progressive and it goes up only. In asthma, symptoms happens mainly in the night or early morning, while in COPD, it can be throughout the day. There is a long history of tobacco smoking present in COPD, while history of atopy, allergic rhinitis, or eczema, or family history, that is what is present in asthma. Asthma is a reversible airflow obstruction. Now you should be, when I'm saying word reversible, what should come in your mind is 12% reversibility, more than 200 ml absolute value in FEV1. So this is how, while COPD is reversible, so that is how you should differentiate asthma from COPD. Now, when you diagnose asthma, there are different subvariants. It's not phenotypes. Actually, you can tell this as a phenotypes of asthma. There are some asthma which are cough variant, sometimes occupational asthma. When the person is working in a bakery or a factory, and they particularly come that only like Monday morning fever. When they are off on Saturday, Sunday, they do not develop fever or any symptoms or wheeze, but when they go to their workplace, they develop asthma. That is very classical history, and you should ask for it for your patient. And then there is exercise-induced asthma and aspirin-induced asthma. These are all different phenotypes which you should be aware of. I'll say something about exercise-induced asthma because that is also quite common in clinical practice, and parents might be coming that the children cannot play as much as their other peers can do. So how exercise can cause asthma? So exercise can lead to hyperventilation. When you breathe fast, the airway becomes dry and the air becomes cool. Because of that, there is a stimulation of vagal receptors in the airway, and there is a release of histamine and some chemoreceptive factors from mast cells, which I have already discussed, those all the groups of the chemoreceptive factors, which can cause reduced cyclic AMP, which is a muscle relaxant response to airway smooth muscle. And the stimulation of vagal receptors can cause muscle contraction. So all the sympathomimetics will contract the muscles and patient will develop bronchospasm. So these are all the blocks which I have put here are the drugs. You can use chromoglycate, you can use H1 receptor blockers, or you can use anticholinergic drugs, or you can use beta-2 agonists for relieving those asthma. Now, asthma comorbidities and mimics I have already discussed, but you should remember one more, that is obstructive sleep apnea. Now coming to the initial part of asthma management, which is prevention of exposure to triggers. The first and foremost thing you should be knowing is how do they live? What are the factors in their house which can be causing the asthma? You should be spending some time with your patient, talking to them and educating them about the preventive measures. So tell them to use bedding encasements, or you can ask them to wash bed linens weekly, avoid down feelings, limit the stuffed animals which are always loved by all children, that limit it only to the washable ones. Reduce the humidity level. It's very important in this part of country, Kerala, where the humidity levels are high. So reduce the humidity level by putting AC or air dryer or something. And those are the small things which you can. Second thing is reduce the exposure to environmental tobacco smoke. Evidence suggests an association between environmental tobacco smoke exposure and exacerbation, and it is also showing the environmental tobacco smoke can cause asthma even in preschool children. So if the parents are smokers, then the kid is going to be affected. So you should encourage them to stop that smoking and passive smoking to their kids. Reduce the exposure to cockroach. If you remember, cat, cockroach, and dust mite are the most common allergens. So dust mite I covered in my first slide. This is the cockroaches. You should tell them that remove as many water and food sources as possible to avoid cockroaches, and reduce the exposure to pets. You should at least ask. Even I make it a habit. I have made my habit to ask all my asthma patients, do they have pets? Pets includes dog, cat, even outside the house, or birds. Anything they should. You should discourage them, not discourage them from having any pets. Then reducing exposure to mold, which will increase the, like in a humid climate like Kerala, is very important, and many patients come because of the damp environment, and the air which they are inhaling is so much of like the air is so much impure that it includes many allergens which they inhale, and it will indirectly cause the exacerbation. Many cleaning staff come to me telling that they, once they were exposed to this, they developed exacerbation. So all those kind of factors you should try to avoid. Other asthma triggers are air pollution, trees, grass, and weed pollen, exercise, anything. Please keep a broad mind, and please try to find out what is causing the problem to your patient. Now coming to the asthma control. So levels of asthma control can be divided into controlled asthma, poorly controlled asthma, and uncontrolled asthma on the basis of daytime symptoms, limitation of activities, nocturnal symptoms, need of reliever or rescue medicine, lung function, and exacerbation. If none of these are present, then it is called well-controlled asthma. When the daytime symptoms, any of this is present in any week, any one of this, then it is called partly controlled. And when more of these are present, three or more of these are present, it is called uncontrolled asthma. Now, we should be diagnosis our asthma as a controlled, well-controlled, and uncontrolled asthma on the basis of these all symptoms. I think I am coming to end of my part 2 presentation.